Good afternoon, folks. This afternoon's topic A. The title is to the article is "More Seniors Are Using Drugs for Pain Control." Here's why it matters. Highlights a concerning trend in marijuana use among older adults in the U.S. Here are the main points. Rising marijuana use among seniors. A recent study from JAMA Internal Medicine found a nearly 46% increase in past month marijuana use among Americans aged 65 plus from 2021 to 2023. The study analyzed data from nearly 16,000 older adults across diverse demographics, gender, race, income, and education, showing widespread increases. Lack of public response. Despite the sharp rise in public and policy response, has been muted. The author calls for senior-focused prevention efforts, emphasizing that this issue deserves more attention from legislators and health policymakers. Broader implications. The article suggests that the shift in drug use patterns among seniors could have serious health and social consequences, especially given age-related vulnerabilities. Would you like to explore how this trend intersects with frailty-aware care models or memory-friendly housing strategies? Increased marijuana use among seniors carries several health risks that are, give me 1 second, guys, especially concerning. Given age-related vulnerabilities. Here's a breakdown of the key risks. Okay, guys, I'm going to go through these for you all now. Cardiovascular risk, heart attack and stroke. Cannabis use, whether smoked, vaped, or ingested, can increase the risk of cardiovascular events. Daily users are significantly more likely to experience heart attacks. Blood pressure fluctuations. THC may cause blood vessels to constrict, raising blood pressure temporarily. Cognitive and neurological concerns, memory impairment, and slower coordination. THC can affect attention and retention time, increasing fall risks. Dementia risk. Seniors requiring emergency care for cannabis-related issues had a 23% higher chance of developing dementia within 5 years. Increased emergency room visits. ER visits among seniors due to cannabis use have surged up to 395 per 1,000 visit in California. Many incidents stem from overconsumption of edibles, which can lead to anxiety, hallucinations, panic attacks, drug interactions. Cannabis may interact with common medications like warfarin, opioids, and benzodiazepines, potentially altering wait 1 second, guys. Their effectiveness or increasing side effects. Safety and functional risks. Fall and driving impairments. THC affects motor coordination and balance, raising the risk for accidents. Misjudging potency. Seniors unfamiliar with modern cannabis may underestimate THC strength, leading to adverse reactions. Addiction and dependency. Studies show that up to 36% of older users may meet criteria for cannabis use disorder, especially among veterans. Would you like to explore how these risks could be marijuana use can impact cognitive function in seniors in both potentially harmful and surprisingly beneficial ways depending on dosage, frequency, and individual health status. Here's a nonsense summary of current findings. Potential cognitive risks. Short-term impairments. THC, the psychoactive compound in cannabis, can disrupt working memory, attention, and executive function, and psychomotor coordination. Dementia risk. Seniors who visit the ER for cannabis-related issues were up to 4 times more likely to be diagnosed with dementia within 5 years. Accelerated brain aging. Some studies suggest cannabis abuse may prematurely hold on. Age the brain. Nearly 3 years, similar to effects seen in bipolar disorder or alcohol abuse. Possible cognitive benefits. Improved brain connectivity. Low dose cannabis use in older adults can be linked to stronger functional connection between the hippocampus and cerebellum, regions critical for memory and learning. Neuroprotective effects. Animal studies show that THC may reduce brain inflammation and promote neurogenesis in age-related brains. CBD role in high CBD cannabis, often preferred by older users, may counteract age-related cognitive decline due to its anti-inflammatory properties. Mixed evidence and research gaps. Limited human studies. Most research is either animal-based or cross-sectional, making it harder to draw uh, causal conclusions. Dose-dependent effects. Extremely low doses of THC may enhance cognition in older rodents, while higher doses can impair it. Okay. Need for better controls. Studies often lack controls for chronically routes of administration and coexisting health conditions. All right. Would you like to explore how these findings could inform frailty-aware care models or memory-friendly housing design, or perhaps dive into how therapeutic alternatives like dance therapy or mindfulness compare in cognitive outcomes, mitigated through frailty-aware care models or personalized therapeutic alternatives. The findings on increased marijuana use among seniors have significant implications for senior care practices. Here's how they could reshape care models, policies, and clinical protocols. All right, folks. We're down to clinical adaptations in long-term care settings. Screening protocols. Clinicians are urged to routinely screen older adults for cannabis use using tools from the National Institute on Drug Abuse. All right. Medication reviews. Cannabis can interact with medications for heart disease, diabetes, COPD, and cancer, conditions common in seniors. Care planning. Facilities must integrate cannabis use into individualized care plans, especially for residents with mobility issues or cognitive decline. Legal and regulatory challenges. Federal restrictions. Cannabis remains Schedule 1 drug, uh, complicating its use in federally funded nursing homes, Medicare compliance facilities, risks losing Medicare certification if they permit cannabis use, even in states where it's legal. Policy gaps. Assisted living communities in states like California and Colorado may allow cannabis use but lack standardized dosing and safety guidelines. Mental health and quality of life. Mood enhancement. Cannabis may improve mood and reduce anxiety, potentially enhancing social interaction and reducing isolation. Alternative to opioids. It offers a non opioid option for chronic pain, which could reduce dependency and side effects. Okay, risk management and best practices. Safe storage and administration. Communities must ensure secure storage and assess residents' ability to self-administer cannabis. Mobility and fall risks. Impairment from THC requires monitoring, especially for residents using mobility devices. Staff training. Policy should prohibit staff from acting as designated caregivers or administering cannabis unless required by law. Okay, education and communication. Resident and family engagement. Facilities should inform residents about cannabis policies during admission and encourage open dialogue. Okay. Let's see. Professional guidelines. Guidance. Seniors should consult healthcare provider to weigh benefits and risks, especially regarding dosage and drug interactions. Would you like to explore how these care adaptations could be integrated into frailty aware or memory friendly housing models, or perhaps how therapeutic alternatives like dance therapy or mindfulness compare in effectiveness and safety? The findings on increased marijuana use among seniors have important implications for teamwork in senior care settings. Here's how they could shape collaborative policies. All right. Interdisciplinary coordination, care planning, integration. Teams must include cannabis use in individualized care plans, especially for residents with cognitive decline or mobility issues. Medication consolidation. Pharmacists, nurses, and physicians need to collaborate to monitor drug interactions, especially with common medications for heart disease, diabetes, and COPD. Mental health support. Social workers and therapists should be involved to assess mood changes and potential cannabis related anxiety or depression. Policy and compliance alignment. Legal awareness. Administrators and legal advisors must ensure compliance with federal regulations, especially in Medicare funded facilities where cannabis use may jeopardize certification. State specific protocols. Teams in states like California, Colorado may need to develop standardized dosing and safety guidelines for cannabis use. Risk management collaboration. Fall prevention strategies. Occupational therapists, nursing staff should monitor THC related impairments that increase fall risks, especially for residents using mobility devices. Safe storage and administration. Staff must coordinate to ensure secure storage and access, residents' ability to self administer cannabis safely, education and communication, resident engagement. Teams should involve residents and families in discussions about cannabis policies, drug administration, and care transitions. Staff training. Facilities must train staff on cannabis related risks and prohibit them from acting as designated caregivers unless legally required. Okay. Cognitive health monitoring. Now, folks, we're at the last page for today's 8. So I will finish this one up. Neuropsychological assessments. Psychologists and neurologists may need to evaluate cognitive changes linked to cannabis use, especially in frailty aware or memory friendly environments. Therapeutic alternatives. Teams can explore non-pharmacological interventions like dance therapy, CBT, or mindfulness as complementary or substitute treatments. Would you like to explore how these teamwork adaptations could be modeled in smart housing environments or integrated into caregiver training programs? All right, so that is A for now. I'm going to go take a break, and I will see you guys back for shows in a little while. For now, Gator Wellness, take care, folks.